Dr. Koka, hello again.
Hello, how are you?
Fine, how are you?
Good, good.
So, are we talking about tPA in stroke and whether it should be abolished or banned or?
We are because the world of stroke needs more cardiologists talking about strokes. So this all got started because John Mandrola, who's a incredibly thoughtful, good guy who's been writing blogs for a while, weighed in on a controversy that I guess I didn't realize was simmering on thrombolytics, systemic thrombolytics, and the use of acute ischemic stroke. And I guess the small backstory is that there's a emergency medicine physician, maybe a couple, but especially one who's especially a proponent of the idea that the data on systemic thrombolytics for stroke, acute ischemic stroke, is very poor. Gina Colota, who's the healthcare journalist for the New York Times, then wrote an article, and she essentially talked about the controversy and essentially cast the article as the article was cast as beware what you read on the web, beware about these blogs, because the gentleman who's the ER physician who's writing against systemic thrombolytics for stroke is a physician who blogs a fair amount, and essentially she poo-pooed his concerns after talking to and quoting a number of neurologists in the piece. So John came in out of the blue and weighed in on this, and he did his own review of the primary data. And his own review of the primary data suggests that we shouldn't be using systemic thrombolytics for stroke. So I'll stop there, Michelle, after giving you the backstory, and ask you what you think of that so far.
We shouldn't. It should be banned altogether.
Well, he thinks that he thinks that it's there's no good data to support
maybe
it.
He's not going that far, but that. Yeah, I mean, I don't want to. What is it? What is it for him? I mean, I understand. Maybe he thinks that the risk is too great and the benefit is too small, and
Right.
But why always butt into what other people are doing?
Well,
in a sense,
yeah.
I have no idea what whether I can see that it's risky, that the benefit is not clear.
Shouldn't we be concerned as physicians if there's some toxic drug that's being delivered without any
without the permission of somebody else?
Uh,
and that's what it is. It's we want to give permission, and by what criterion? So what level of effectiveness and what level of harm?
Yeah.
John,
right. Great question. So John seems to have done again, I don't, John is going to force me to read freaking primary thrombolytic literature in stroke now, but I haven't actually read through the studies, but John went in detail into some of the randomized control trials on the topic. There are only two large trials. Apparently there are two trials, the NINDS and the ECAS trial, that were positive, and neither of them showed a mortality benefit. The only benefit seen was in the neurologist's functional score outcomes, and he casts a fair amount of shade on them. One, because they're subjective, and two, because a reanalysis of the NINDS trial, which is one of the big positive trials, showed that if you consider where the where the functional score was from initiation to where you were after tPA, there was no change.
Mm-hmm.
So that seems kind of somewhat damning. That, well, you're giving tPA, but the score is not changing from baseline to what it is after thrombolytics. So it turns out that the difference had more to do with what the final score was in the two arms, but it didn't take into account what the baselines were in the two arms.
Mm-hmm.
Meaning, there's something there's something fundamentally different about the two groups in terms of who got tPA and who didn't get tPA. So So yeah, so I mean, and then of course John goes into the toxicities associated with tPA, and there's clearly more bleeding, more hemorrhagic. There are more intracranial bleeds that are seen when you give tPA.
So I can see his point. I can see his point, and I can see that doctors, neurologists, maybe not acting as wisely as they should. On the basis of the objective data. I'm not sure if I were a neurologist or an emergency room doctor, what I would do. But the main problem is the enthusiasm for tPA in acute stroke really comes top down. It's come from academia. It's come from the NIH. Trying to follow on the heels of what's happened in cardiology. So cardiology, we changed our paradigm for the treatment of acute myocardial infarction, and we've had some success that is also actually quite modest, but it's not great, but there's been some success. And so there's a top-down attempt to do this, and incentives put in place by the system at large for hospitals to become stroke hospitals, for emergency rooms. So there's been for years now a huge amount of energy trying to push these acute interventions for stroke. And they came not from, again, they come top down, and they come without any accountability. To me, it's always, I go back to the question of accountability. The people who have pushed thrombolysis for stroke for years and decades are not accountable, and if the trials are inconclusive or whatnot, they're going to be tempted to color them in a more positive light. But there's huge momentum now, and it's very hard to decrease that momentum. So I can see John's point, but really where I differ with John is that in a way, it shouldn't be, because he's misdirecting the attack. The attack is not on the individual doctors, in a given hospital using tPA, because now they're completely conditioned by this massive propaganda that's been going on for 10 years, 15 years. So the attack, really, the criticism should be against the NIH, against the the American Heart Association or the American Neurology Association, or whoever it was that pushed this from the get-go, poured a lot of money into it, and it's always it always leads to problem like that. And I have the same problem with in cardiology with the door to balloon time and whatnot. There's a lot of incentives for hospitals to provide acute interventions, and they don't necessarily do it well, but they do it for the wrong reasons and so forth. I'm not saying that there's no value in doing an acute interventions, but I think if it was left to the devices of patients and hospitals, left alone but being accountable for what they're doing, I think we'd have a better system. But right now it's always sort of top down, these great ideas, the millions and millions of dollars are pushed into them. So the individual doctor who does who provides tPA right now, I think they're maybe they should read John's blog. I have no problem with that. But they're not the primary culprits.
Yeah. I guess two things. One, the things that I worried about what John wrote was, one, it makes me very nervous to get into spaces where I don't have a significant depth of knowledge. I know there's this group of folks that the prior is supposed to be generated only from the published literature, but my God, there's so much missing if you do that, right? Again,
I totally agree.
Harkening back to an earlier conversation we had, you cannot, it's really hard to figure out the truth in a trial without a prior that isn't based on just the published literature. It's like cyclical reasoning to say that we can only use the published literature to figure out what the truth is. So I just automatically have some concerns that not having really ever given tPA, not really managing that group of folks, not understanding the history of where they were and how things progressed, that we may be missing something very, very fundamental by only looking at the 10 RCTs. The other point is that it's entirely possible that there are groups of folks that are benefiting that are hidden by RCTs. So look, maybe most of the RCTs that have been done, not all strokes happen with a collection of red blood cells that are sticking to the others. Many happen because of plaques. Many have, calcified plaque that breaks off. Or maybe some are small vessel strokes. Maybe some are small vessel strokes, right? So, and yes, I realize there are criteria that help determine the size of stroke, and the size of stroke determines whether or not you get tPA or not. But the point is if you take all comers who are coming in with a concern for an ischemic stroke, not all may have a mechanism that benefits from systemic thrombolytics.
Correct.
And so Michelle, if I Ed Schloss, brought up a nice case on Twitter earlier this morning about, the 55-year-old mechanical mitral valve patient who's subtherapeutic, who comes in with an acute stroke, and you're within, 34 minutes or whatever of the patient having acute stroke. It's fairly clear why that person's having a stroke. And, if that's me, and if I'm the physician treating that patient,
you're going to grab the tPA.
Yeah, give this person some tPA. Now, if it's a 85-year-old person that's coming in with a stroke, I think that's a different matter. Meaning that you can see that's at least a different situation. Not to say that the 85-year-old doesn't necessarily benefit.
Correct. I think I agree with you. So on the one hand, there's incentive to treat everybody, quickly, and therefore in the same way, and there are financial benefits for hospitals to be designated as stroke centers and whatnot.
Right.
And that colors, the decision making of the individual doctor. And then there may be doctors, there may be one doctor, one neurologist, or one emergency room physician who may be very good at deciding who to give tPA to and who not to give tPA to. And that individual doctor may actually have very good outcomes that are not reflected in a clinical trial, right? Because the clinical trial will average the effect of all the people inputting into the trial. So if you have a very good emergency department, a good doctor, and it may be the right thing to do. And therefore now, with John's approach, we would penalize people from potentially having a benefit of a reduction in functional capacity, or maybe even more, who knows, even mortality. Why not?
Right.
So I agree. It's always trying to reduce the margin of maneuvers by making broad statements saying we should not do this, we should not do that at all costs, and tying the hands of the clinicians is the wrong approach. On the other hand, I can see that why John would be miffed that we use too much tPA, and there probably is too much tPA being used.
Right. Yeah. No. Yeah. So it's a very thoughtful piece. It's a very brave piece that he wrote. It raises a lot of interesting questions, and I hope someone in the blogosphere will respond in kind. So far, I've heard I'm
seeing that person in front of me.
No, I'm hoping somebody with actual knowledge in the field will respond in kind, as opposed to. But yeah, no, it'll be interesting to see the conversation that takes place going on here. And just in a small note, a little bit inside, it shows you it's really the power of social media is impressive to see. So
fantastic. That's very democratizing, and I think
overall it all started with the ER physician blogging, and now John is blogging about it and seeing some interesting signals, and now we're all talking about it, within hours. So it's amazing. So anyway, but yeah, good point.
Sounds good. Have we liced that one?
Yep,
we've liced it. Okay. All right, Anish. See you next time.
Take care, Michelle. Bye-bye.
Bye.